Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today's topic, pseudo-resistant hypertension, an elevated blood pressure that appears to be resistant to treatment, but actually isn't. But before we get into that, make sure you check out the other videos at this channel. Check out bcnephro.com where you'll find articles not only on this topic, but on a wide range of nephrology subjects. I'm also on Instagram at bcnephro. Links to all will be in the description below. Now, let's get into it. Resistant hypertension is defined as a blood pressure that is not controlled to target despite the use of 3 medications of different classes, at least one of which should be a diuretic at maximally tolerated doses, or blood pressure that requires 4 or more medications to control. The finding of resistant hypertension often triggers an evaluation for secondary causes, but before we go down that path, we should confirm that the blood pressure really is resistant, exclude pseudo-resistance. Pseudo-resistant hypertension is an elevated blood pressure that is apparently resistant to treatment, but the elevation actually is due to other factors. We're going to get into 5 of these factors today. First, inaccurate blood pressure measurement technique. We need to have accurate readings to make an accurate assessment of what the blood pressure really is. Now, most people know that the cuff should be of the proper size, that a cuff that is too small will give a falsely elevated reading. The proper size of the cuff is that the bladder, which is the part that actually inflates, should be at least 80% of the arm circumference. Now, most cuffs have lines that you can refer to when applying the cuff to confirm that it's the proper size. But there are other factors in blood pressure technique, specifically patient positioning and rest. So the patient should be seated with feet on the floor, back supported, and arm also supported, such as on a table, about heart height. And the patient should be at rest for at least 5 minutes prior to the blood pressure measurement. Contrast this to the way the blood pressure is often measured. The patient is called from the waiting room, either to the triage area or the exam room. If the exam room, they may be asked to sit up on the table where neither their feet, arm, or back are supported, and the blood pressure is taken without any rest period. Now, the ideal way to measure blood pressure, the way that is used in studies, such as the SPRINT study, is to not only have the patient in the proper position with the proper rest period, but to use an automated oscillometric device that takes several blood pressure readings, at least 3, separated by a minute, with the patient unattended. So the medical professional puts on the device, presses start, leaves the room, and comes back several minutes later to get the average of at least 3 readings. Comparing this way to standard triage measurements, you may find that there's actually pseudo-resistance in up to 1/3 of patients. Now, proper technique is also important for home measurement. So when the patient brings in their monitor for validation, it's useful to actually have them perform that measurement themselves to show you how they do it. And when reviewing the log, if you see significant lability, a wide variability in blood pressure readings, even if taken at similar times of the day, this suggests a possibility that at least for some of the readings, there was not the adequate rest period. Now, people often ask about validation. The Android devices, the ones that you pump up and have this dial, these need to be validated frequently. The automated devices are often quite accurate. Personally, I prefer the upper arm as opposed to the wrist. The manufacturer may recommend validation about every 2 years. This can be done either by sending it back to the manufacturer to validate or by comparing it to a device that you know is validated. The second factor is white coat effect. This is a blood pressure that is elevated in the healthcare setting, but controlled at target in other settings. This can be assessed either by a 24-hour ambulatory blood pressure monitor or home readings. Now, the home readings should be reliable. I find that many patients attribute their elevated office readings to the white coat effect, but then when I question them about home readings, a lot of the time they actually don't even check home readings or check them infrequently. Now, if you're reviewing a log of home readings, be mindful that there should be a random variation of numbers ending between 0 and 9. So if you see the majority of the readings ending in either 0 or 5, this should raise some suspicion about the reliability of these readings. Another thing to be mindful about for the 24-hour ambulatory monitor is that a normal average 24-hour reading is less than 125/75. This is because you need to account for the nocturnal decreased dipping that occurs when the patient is sleeping. A normal a weight average would be less than 130/80. The third factor is interfering medications or medications that can raise blood pressure or impair the antihypertensive effect of other medications. Some common ones are NSAIDs, which may increase renal sodium retention, estrogen-containing oral contraceptives, stimulants such as ADHD medications, sympathomimetics such as over-the-counter decongestants, and cancer treatments such as VEGF therapy. There are many other medications that can cause hypertension, so one should be mindful of this when seeing a patient with apparent resistant hypertension. Fourth is suboptimal medication regimen. So the patient should be on at least 3 medications of different classes, and one should be a diuretic at maximally tolerated doses. So in most cases, the 3 medications should include a renin-angiotensin system blocker, either an ACE inhibitor or angiotensin receptor blocker, a dihydropyridine calcium channel blocker such as amlodipine or nifedipine, and a thiazide diuretic. If the patient is not on a diuretic or on 2 medications of a similar class, such as both an ACE inhibitor and an angiotensin receptor blocker, then it cannot really be classified as resistant. Also note that not on the list of preferred medications is beta blockers. Beta blockers are considered 5th-line antihypertensive agents. The doses of these medications should also be adequate. The definition says maximally tolerated, but practically the dose should be at least 50% of the maximum dose to consider the patient truly resistant. So my personal experience in patients referred to me for hypertension that is not controlled is making minor changes such as either adding a thiazide diuretic or changing a non-dihydropyridine to a dihydropyridine calcium channel blocker is often sufficient to get the blood pressure to target. Now, the 5th factor is adherence. This is either poor adherence to lifestyle modifications or medication. The lifestyle modifications we typically know are dietary sodium restriction, weight, and avoidance of alcohol. This is easier said than done, but addressing these factors often allows the blood pressure to be controlled to target. Finally, poor adherence to medications. Now, this is something that is easy for healthcare providers to attribute to, but is difficult to actually truly assess. One thing to be mindful of is that we should be putting the patients in the best position to succeed. So that's avoiding medications that need to be dosed multiple times a day and avoiding medications with significant side effects. So for example, it's not unusual for me to see patients who have been hospitalized with hypertensive urgency to be discharged on a regimen including clonidine, labetalol, and hydralazine, all 3 times daily dosing medications, and the first 2 have significant side effects, can make the patient feel like crap. So it's like, no kidding, they're not adherent. We should be using medications, ideally that are dosed once a day and have minimal side effects. Now, there are many suggested ways to assess adherence, including pill counts, pharmacy refill data, and measuring the drug metabolite in the blood or urine. But I think the best way, if you really want to assess this, is directly observed therapy. Now, this kind of happens in the hospital. The medication is administered and the blood pressure measured, but also can be done in the outpatient setting. So the way to do this is to have the patient bring all their medications into the clinic, have them take 1 medication every 30 minutes, assessing the blood pressure each time, and document the effect. Now, personally, I have not done this in the office, but I have done this in the outpatient dialysis setting when the patient is there for several hours anyway and having the blood pressure measured anyway. The way I frame this to patients is that we want to see which medications work and which don't work, and what the effect of each different medication is to make a better assessment going forward. Now, like the other factors with directly observed therapy, about 1/3 of patients can be found to actually have pseudo-resistant as opposed to truly resistant hypertension. So that's it. Thanks for watching. Pseudo-resistant hypertension, blood pressure that appears resistant to therapy but actually isn't. If you made it this far, you might as well hit like and subscribe. Please share this video with someone who you think might be interested in learning about this topic and spreading the message word of mouth. That really helps the channel grow. Leave a comment or question below, and until next time.